Okay, good morning everyone. I'm just going to run through about how we will do a TACE. And on this Mentis program, when you guys come in, this case that we're going to talk about that I'm going to be using as an example is the one called Basic TACE Case 1. So in this case, just wait for it to load. I'm going to talk you through a little bit about each step and how I might do it, and in general terms, how it can be done. So this scenario talks about a 63-year-old man who has an abdominal sonogram with what they say here is a 2 by 2 centimeter mass. Went on to have a liver CT, which showed this hyper-enhancing lesion with washout and no lesions in the left lobe. What I would say to you is that a lesion of this size would normally now be treated with ablation. So for simulation purposes, let's say that this mass is 5 centimeters within the right lobe of liver, and that will be the premise. So once you have reviewed your pre-procedural imaging and you understand, number one, where the lesion is, it's very important to do your pre-procedural planning. And your pre-procedural planning can be very much done on say, the liver triple phase CT. And you need to look at your arterial anatomy. You need to know what roughly you can pick out where the celiac axis is, where SMA would be, look at the portal vein, if you have a CT, because that will tell you if the portal vein is patent or not. You'll also be able to map out your vascular anatomy. So on your celiac trunk, you need to know where, for example, you could map out where your common hepatic arteries are, where your right gastric is, and also where your GDA is in relation to possible embolic point, and also potentially your cystic artery. So as you can see, before I've even reached the patient or started anything, there's a lot of pre-procedural planning that can happen for these procedures. When you come to deciding about the TACE, other important things would be things like Child-Pugh score, would also be important in determining what treatment you're going to do. Specifically for this TACE procedure, I'm just going to tell you literally the different aspects, and then we'll show you using the Mentis just some areas that I want to highlight, rather than going through each step where to select a catheter or etc. in the Mentis. I'm just going to show you, use that as a guide. So for this particular procedure, if we have decided that we're going to do a TACE, there are different ways nowadays that this can be tackled. So even at the site of access, you can either use a femoral access, as this will be simulated here on the Mentis, and nowadays someone like me personally would probably use a radial access to do this procedure. So if you're using a femoral access, whatever access way that you have been taught, for example, I personally would use a micropuncture access and probably place a 6 French vascular sheath. If I'm using a radial access, I'll use my standard radial kit. I generally access the left radial artery so that I avoid crossing the aortic arch when I'm coming down the thoracic aorta to get into the celiac. And some things to note, depending on which access point you use will determine what catheters you may use. So from a femoral point of view, catheters that may be used, you could use a Cobra catheter, for example, to access your celiac axis. You could use a Sims catheter to access your celiac axis. But all these catheter preferences should be known before you even start the procedure, how you might plan this. So if, as in the Mentis is going to show, for example, if we're using a femoral access and I choose to use a Sims catheter, probably 100 centimeter length or so, the specifics of a Sim catheter is that once I place the catheter into the patient, I would pass the catheter up to the level of the diaphragm, and I would take the wire out at that stage, and I would aspirate the catheter and flush it. This is to try and avoid any possibility of sending off clots or emboli when you go up to form the catheter higher up in the thoracic aorta or the aortic arch. Obviously, that's not necessarily required if you're using another form of catheter like a Cobra catheter where you're not forming the catheter loop. If I form the Sims, I would bring it back down. There are ways, most people would probably put a wire just outside the tip to prevent any catching off of any blood vessels and to be as atraumatic as you can. Some people may use contrast, but I personally would use the wire tip. From a radial access point of view, the catheters are a little bit different. Personally, I use the Merritt catheters, so there's from ultimate 1 to ultimate 3, which determine the curve, and obviously they are of different lengths. And after I get access into the radial artery, I would pass the catheter, come down the thoracic aorta, and I'll enter the celiac axis that way. So as you can see, depending on where your access site, depending on what center you work in, will determine what kind of catheters, or what I call base catheter, you would use for this procedure. Okay, so now that we're back to the recording, what has happened in the interim is just that this particular program will ask you to cannulate the SMA, which I've done, which is not a usual practice anymore, especially given that most patients would have cross-sectional imaging ahead of time. So we used to have to do flush angiograms, and with delayed phases to look for portal vein patency when we didn't have as much access to cross-sectional imaging. That probably is not done anymore. And certainly before I get into almost any of these procedures now, I would have some degree of cross-sectional imaging, so that is not really as evident. So what I've done is I've reached a point where I've put my catheter into the celiac trunk, and now I've done my first angiogram from that catheter. What this has shown me is the anatomy of the hepatic artery, and also you can see the enhancing lesion that we talked about. And just use the cursor here just to show you. So here's the lesion that would have been hyper-enhancing on the original CT, and that's the lesion that we would like to treat. From here, depending on if you had come from radial, the catheter will be coming down and scooping in like that, or obviously from the femoral it comes up and goes this way. What we are looking here from the vascular anatomy is to try and find out which arterial branch or branches supply this lesion, because that's what we want to treat. From here, I would choose a microcatheter and microwire combination, and there are different microcatheters that one can use. Obviously, to do these procedures, we want to do cone beam CT as probably part of them. So I would personally choose a microcatheter that has some degree of high flow. I can take a catheter pump run as part of that process. I know in the Mentis program there's no cone beam CT, but this is just another way that one can check to make sure where you're embolizing from is satisfactory. Okay. So in this scenario from here, I would probably take a microcatheter microwire. I would certainly interrogate and probably come up this artery and make sure and do angiograms. And I would also check this one on the way out and make sure and do angiograms to just see if there was one supply, dual supply, or if there are any other arteries that, and this is where your interrogation of the lesion is very important, because that will determine your likely success for treatment of this lesion. Because if you leave any open arterial branches, this tumor will just recruit vessels from that site and from other sites, and might, you won't get a proper treatment. So what I would say to you is that when you're doing a TACE, this is why you interrogate the arterial anatomy. You also, as I said, looking for where is the celiac artery if you can find it. Yes, I can, on previous angiograms, you will probably see the gastroduodenal artery come down in this way. And I would have already identified where the right gastric and the left gastric arteries would come from. Once you are happy that you have your microcatheter in a position that is acceptable, and that you have found the arterial feeder that is supplying this tumor, at that stage you are then in the position to perform your chemoembolization procedure. Now, depending on what center you work in, that embolic might be different. So we have different, you have lipoidal TACE, you have DEB TACE, and these are all different chemical modalities or particles and chemicals that are used to help to treat these lesions. In DEB TACE or doxorubicin encoded beads, there are small particles that are used that get distally out. There are small particles that infiltrate the tumor bed, vascular bed. So the idea would be to get your microcatheter to the point where you are sure that you have covered all the arterial tree. You would then inject your whatever chemical substance that you use or embolic that you use. And what you want to do, say in the setting of a DEB TACE, you want to get to stasis. So if you have injected all your particles that you have which have been impregnated, then you would also want to consider injecting some bland particles after that, i.e. non-coated particles as part of the procedure till the point where you get arterial stasis to the lesion. Okay, that is the key. If in some centers they don't use chemo beads or a chemo agent, some centers they do what they call bland TACE, which is basically where you use normal particles to perform the embolization. Okay, the idea is that you really should be using small particles to get that distal infiltration into the tumor bed. And so they would probably start off with probably 100 microns, and in some places 50 micron particles to get out to that kind of infiltration that you want to get. Once you have stasis and you're happy with your procedure, at that stage your procedure is pretty much complete. You would remove all your wires and catheters, and then you need to think of closure of your access point. Your closure will depend on what access you have and what closure devices may be in your center. And I don't think this is the time to discuss all of that, but that's something just from a local point of view that you would need to consider. After you do the procedure, the patient should be, and you have had your hemostasis, your patient should be sent for observation for post-procedural care. And most centers will have a follow-up imaging performed somewhere that is a predetermined thing. I tend to do this somewhere between anywhere between 6 and 12 weeks, depending on what center you've worked in, as the first initial follow-up. So at that stage, I will end this recording.